My practice consists of a lot of patients that are geared toward having an endoscopic or ureteroscopic management of a kidney stone because they have some sort of precluding factor that either they personally do not want a percutaneous nephrolithotomy, they're not a good candidate for shockwave lithotripsy, or they have some sort of predisposing factor that would make it better for them to have a ureteroscopic management. And it tends to be a lot of stones that are on the larger size, from anywhere above typical guidelines of like a 2-centimeter stone all the way up to full staghorn stones that we manage sometimes with a less invasive approach. So a lot of the patients that I see are patients that are on a lot of blood thinners or a lot of other medications for other reasons, typically cardiac reasons, and those patients that cannot stop their anticoagulation or their antiplatelet therapy. We will tend to manage them ureteroscopically in a stage or two. So we'll lots of times do very large sized kidney stones, and you'll either do it in 1, sometimes 2 stages where you put up the scope and you can keep patients on their anticoagulation or blood thinning agents while they're doing that type of surgery, because ureteroscopy in general is fairly safe in that type of setting. So it takes time. You have to grind up that stone and you use lots of different laser settings in order to do it appropriately. Usually for these larger type stones, we'll start off, first you just want to have clear visualization. You always want to keep the bladder decompressed when you're doing these types of longer procedures so the bladder doesn't get very distended, and it keeps your visualization more clear. You can either do that with something called the ureteral access sheath, but even easier sometimes is just putting a catheter into their bladder at the same time that you're doing the ureteroscopy to keep the bladder drained. And then it's just meticulously going through the stone, going from one area to the next, grinding it up into little fragments and dust. So there are different laser settings that are used to fragment and dust stones. We do a large volume of these types of cases. I always start off at the same setting. My first setting is always 0.6 joules and 6 hertz. And then from that, I immediately can decide whether this stone is going to fragment well and how well I can see it. And then I start moving around my laser settings where I'm either going at a very slow power and a rapid rate to dust a stone versus a higher power, maybe less, like stay on a slower to medium sized rate in order to fragment it into little particles. Depends on how hard the stone is and how easily it dusts. So if it's turning into where the visualization is impaired, then I will sometimes change the settings around in order to make it so the visualization is clearer and so that you can accurately see the rest of the stone. Where you use a fast rate and a slow power type of setting is considered dusting, where you just slowly, meticulously go over the stone and keep creating fine dust. When you use fragmenting, you're breaking bigger and bigger particles that are easier to extract, but you're, again, trying to get it to 1 to 2 millimeter little fragments so that it's easier to either extract or still potentially pass as you grind it up smaller and smaller. So we have our big dusting and basketing study that has been presented several times now, being written up into a manuscript to show that the effectiveness of dusting probably has a little bit lower complication rate, probably has shorter time for the surgery, but has a little bit higher residual fragment and a little bit higher cost with basketing out stones. So that type of data is panning out, and more studies are going to be done on that, trying to find out what's the most efficient and safe way to do this type of surgery. And the big decision at the end is whether you're going to let the patient try and pass the little particles or whether you're going to actually extract them. When stones get bigger and bigger, the extraction becomes much more onerous on the physician and much more, it can prolong a case quite often. So I will tend to dust it into small little particles that'll be easier for the patient to potentially pass. And then about a week after the surgery, we'll give them an opportunity to try and pass all of this when I remove the stent. And if they're unable to, possibly then go on to a second stage procedure. But quite often on the more medium to larger size stones, they're able to do it in one stage, at least in our hands. So the one biggest point about doing endourology is that you have to have a full armamentarium of equipment if you're going to do it well. So you have to know all of the disposable equipment that's available to make the surgery safe and effective. So one, be very familiar with all the products that are out there that can make your life easier. And two is know when to use them. I mean, the technology is only going to expand upon where it's at right now, so the disposable should get better. The optics should get better. If technology increases the way that it is, it'll just make this procedures potentially safer. Something to be able to extract fragments of stone or suction out fragments of stone without having to extract it and leave patients stone free would be a tremendous innovation.